Hey, I'm Gary Chimes from Lake Washington Sports and Spine in Bellevue, Washington, and we're going to talk about the wonders of dynamic scanning of the shoulder. So I have my shoulder model Jacob here, and the first thing I want to talk about a little bit is about positioning. One of the things I want you to notice is that if we look at the length of Jacob's upper arm, it's a little bit shorter than his trunk is, and what happens is, hey Jacob, can you show how you tend to slump forward? If the weight of his arm will make it so that his shoulder will slump into a position that's really not ideal for scanning. So one of the pearls that I love to use is to actually have a pillow on the waist of the patient and have the arm centered towards the weight of the pillow. And what we find is that for most patients, their arm length plus a pillow length equals that of the trunk. So that's going to be the first pearl. Before I go into the wonders of a dynamic scan, I'm just going to show how you would quickly do an overview scan. So first thing I'm going to do is get some gel. A little pearl is if you kind of rotate it and give it a little thump. That will help get the gel into the right spot. And I'm going to be putting the gel onto the patient for what's going to be the bicep scan, which is going to be the first part of the shoulder scan I'm going to do. And I'm just going to bring it across the front here. And what I'm going to be looking at is going to be looking at the biceps. So I'm going towards the front and I'm going to look for the double mound of the lesser tuberosity, which is going to be to your left. And that's going to be where the subscapularis tendon attaches. And I'm also going to be looking at the greater tuberosity on the right. And between those, you're going to see the biceps tendon. You can play with anisotropy. It should be bright white. If it looks black, that's because you have the wrong angle. And we're going to be scanning up and down. That's length in the short axis. And then you can also look at a long axis view where you can see the biceps tendon as the bright white fibular architecture that is deep to the deltoid. What I'm going to have Jacob do is if you can put your shoulder into maximum external rotation, that's going to be bringing your arm outward, and that's going to allow us to look at the subscapularis tendon and muscle. I'm just going to change the depth a little bit. So what I can see is the bright white fibular architecture of the subscapularis tendon deep to the deltoid muscle. And then I can see a little, where the bird's beak, there's an inflection point. We're going to be seeing the anterior humeral head. When I'm looking at that anterior humeral head, what I can see is a thin layer of hyaline cartilage. I actually can go to greater depth by adjusting the depth on the machine. And Jacob, if you wouldn't mind bringing your shoulder into even more external rotation, I can see that anterior part of the hyaline cartilage, and you can look for things like glenohumeral arthritis. Just superficial to that hyaline cartilage, I can see the myotendinous junction. So most superficially, we have a deltoid muscle, and then underneath that, we have a subscapularis muscle attaching to the subscapularis tendon, and then I can trace it all the way to its footprint onto the lesser tuberosity. If I continue to scan medially, I sometimes have to go a little bit superiorly in this transverse plane. I can then see the coracoid bone. If you look at that coracoid, you can see that to the right, you have the subscapularis. So you can actually have an anterior impingement of the subscapularis muscle underneath the coracoid. So Jacob, if you would be kind enough to slowly internally rotate your shoulder, and you can see the tendons going underneath the coracoid, and then go back up. Okay, go back into that externally rotated position, and we can see the muscle belly of the subscap going underneath the coracoid. That's pretty sweet, right? Next thing I want to do is take a look at the pectoralis minor muscle. This is something that you sometimes don't see in standard shoulder protocols, but I actually think it should be part of one. It's a really common cause of shoulder pain. And what I'm going to do is, from where I've done that subscapularis scan, I see the coracoid, and it's going to be actually in an oblique transverse plane. So it's a little bit at an angle. If you look at the anterior chest wall, you can see the probe is actually at a little bit of an oblique plane. And what I can see is that there is, I'm going to make the depth a little bit deeper, is I can see on the far right of the screen, which is going to be lateral, I can see the coracoid. And from there, going out laterally, I can see the tendon and muscle belly of the pec minor. Okay, and you can see the pulsating vessels. Now, if I apply more pressure, you can see it's actually collapsed down the axillary veins, but the axillary artery is still pumping there. The brachial plexus is going to be, we're going to be looking here at the level of the cords. So the cords of the brachial plexus are going to be named relative to their position of the axillary artery. So you're going to see, for example, a little cluster of nerve tissue. The way that you identify nerve tissue is it's often described as a honeycomb appearance. I personally think it looks a little bit more like a passion fruit, but whichever fruit that you happen to go with. And so just to the lateral, in this case, which would be to the right, you're going to see the nervous tissue of the lateral cord of the brachial plexus. You can see the posterior cord deep to the axillary vessel, and you can see the medial cord to the left, which would be medial of the axillary vessels. One of the things I want you to see is that the pec minor is tenting upward, and what I mean by that is the concavity is pointing downward, which is deep. In somebody who has a pec minor in ideal alignment, it would actually be concave upward. So this is going to be related to a shortening of the pec minor, and when you see a shortening of the pec minor, one of the things you want to be concerned about is this is a potential target for rehabilitative treatment and rehabilitative exercise. You can, if you want to, trace the pec minor all the way to its attachment to the rib. Another thing you can do is spend a little bit of time is applying pressure on where the pec minor is attaching to the coracoid. A lot of times people will have something called a sixth scapula, and one of the characteristics is coracoid tenderness right at that medial attachment to the coracoid. Next thing I would be scanning over to is to take a look at the coracoacromial ligament. So that's coming from the coracoid on the left, going over towards the acromion on the right. From there, I'm going to make the settings a little bit more superficial because we're going to spend some time on the AC joint. Right now, we're looking at the AC joint, so I may even make it slightly more superficial. And so medial is to the left, so I'm looking at the clavicle, and sometimes you're looking there for like an osteolysis of the distal clavicle, especially in like those weightlifters. And then as I scan to the right, I'm looking more at the acromion. And there you can see a nice flat looking capsule. Sometimes in patients who have osteoarthritis, you may be looking for things like cortical irregularity, you may be looking for some cystic changes, you may see some bubbling over, you may see some stuff kind of floating around in that synovial fluid. One of the things that we'll actually do is do a little bit of a dynamic test. I'm going to be pulling the cord over behind his back so the cord doesn't get in his way. And then, Jacob, if you would be kind enough to slowly put your right hand on your left shoulder. I'm just looking for abnormal motion patterns, particularly a lot of abnormal narrowing. It is having fairly normal motion. It should move. It's a joint, so of course a joint should move, but we're not seeing any abnormal narrowing, any abnormal geyser sign forming. Okay, cool. Let's have you go put your arm back into that position. Now, one of the things I want you to see is the relationship between the acromion, which is again on your right, which is lateral, and the supraspinatus tendon. The most important structure in the whole shoulder that we want to look at is the supraspinatus tendon, which is the most important of the rotator cuff tendons. So there's the acromion, and as I come over, I can see the supraspinatus tendon in view. So you can see on the screen, you see on the left medially the acromion. Then you can see the supraspinatus tendon in the middle of the screen sitting over the black hyaline cartilage of the humeral head. And then you can see the footprint of the tendon on the greater tuberosity. One thing that's really nice in this view is that you can see there is a bursal fluid, and that's going to be between the supraspinatus tendon and the deltoid. This is one of the greatest strengths of ultrasound, is you can actually see this where you often have to infer it on a lot of other imaging modalities that don't have this level of resolution. One of the things I'm really making a point of in this view is I'm applying pressure to the acromion. If I push down on the lateral aspect of the probe, and if the cameraman can kind of focus in right on there, what's happening is I'm actually collapsing down the bursa. So when I do the scanning, I actually want to be applying most of the pressure to the acromion rather than to the lateral aspect of the probe. Now, one of the problems here is I can't really see a lot of the anatomy more medially. So what I really need to do is put the shoulder into a position so that the greater tuberosity is going to be rotated. So what I really want to do is that this greater tuberosity, I want to bring it forward. And there's a couple different ways to do that, but in this case, I'm going to go into what's called a modified Cras position. And Jacob, if you'd be kind enough to put your right hand like you're going into a back pocket, then sit up fairly tall. Now, one of the things that's a little bit tricky, a lot of times patients who have shoulder pathology, this is like saying, hey, I know your shoulder hurts, so you mind if I put you into a chicken wing? So you have to recognize that not everybody's going to be able to handle this well. And in this view, I'm looking long axis on the tendon, but if you look at where the probe is being placed, the probe is actually in a vertical plane. And this allows me to see the tendon in more detail with a wider field of view. So I see the deltoid muscle superficially. And there you can actually see the supraspinatus tendon extending over that really beautiful black hyaline cartilage of the humeral head. One thing that's important is that when you're doing the scan, you need to move the probe left to right, which is making sure you're capturing all the different portions of the tendon. I also want to be able to look at a short axis view, which is called a ball and tire view. And when you do that, you need to make sure you go all the way over medially to make sure you get the biceps tendon into view, which is going to be, the biceps tendon is going to represent the medial margin of the supraspinatus tendon. And then from there, you can go through the different portions from front to back. Next thing I want to do is take a look at some dynamic impingement. So if you can go ahead and put that arm back into that initial home view. Let's actually get you into sort of like your baseline laptop posture. So one of the things I want to do is look for clearance. So I want to look at how much space do I have between the lateral edge of the acromion and the lateral edge of the attachment to the supraspinatus onto the greater tuberosity. So I can just look at that baseline position. Now, can you put your shoulders back into that scapular retracted position? And what I can see is that when I have him open up that space, I actually have a much longer distance between the lateral edge of the acromion and the lateral edge of the supraspinatus. Can you go back into that exaggerated slump position? And what I can see is that distance shortens, and that actually can make someone prone to impingement. So let's actually see that in real time. So one of the things I'm doing is I'm putting, even though I have the entire footprint of the supraspinatus, I'm putting pressure onto my right thumb, which is the part that's sitting on top of the acromion. That way I don't collapse down on the bursa. And if you can bring your arm into an abducted position, I can see it going underneath and go back down. And I can actually see at what angle is his arm when the lateral edge of the supraspinatus goes underneath the acromion. So keep going upward. I'll tell you when to stop. And keep going up. Keep going up. And stop. The lateral edge of the supraspinatus is starting to go underneath the acromion at an angle of about 50 degrees with his body. You can go back down. Okay, can I now have you go into a scapular retraction? Okay, boom, I can see that really opens up the tendon. There's a lot more tendon that's visible. Now, if you can start bringing your arm into abduction again, keep going, keep going, keep going. Good, and I see I just bought him like an extra 30 degrees. Sweet. Okay, bring it back down. And for me, that's really important. You know, usually this combination of focusing on supraspinatus impingement and whether I can correct that with scapular retraction, combining that with looking at shortening of the pec minor, that gives me a lot of information about whether or not I can have this patient rehabilitated. All right, so next thing I'm going to do is have you go back into that baseline position. I'm going to be looking at the posterior shoulder. Now, Jacob's fairly thin, so he's somebody who I'll be able to look at his shoulder using a nice linear probe. Sometimes somebody a little bit bulkier, I may have to use a curvilinear probe. And I'm looking at the footprint of the infraspinatus tendon going onto the greater tuberosity. You can see a little bit of cortical irregularity at the inflection point between the greater tuberosity and the humeral head. And then I can follow this back, and what I'm looking at here is the muscle belly of the infraspinatus. It has a bipennate structure, and that's hanging out over the spine of the scapula. So I want to make sure I look at the muscle belly. I want to look at the myotendinous junction. Now, deep to the tendon, I can see the posterior capsule of the glenohumeral joint. And I actually want to, while I'm in this posterior shoulder, I'm going to want to look at that in a little bit more detail. So, Jacob, if you can maximally internally rotate your shoulder in all the way. What that does is exposes the hyaline cartilage. So I can see that beautiful black layer of hyaline cartilage on the humeral head. For somebody with suspected glenohumeral joint osteoarthritis, I might see some thinning, cystic changes, or osteophyte formation. I can now go to taking a look at the glenoid and the humeral head, so I can look for the capsule and the posterior aspect of the labrum. I continue to go a little bit more medially and then rotate the probe a little bit. I can see the suprascapular nerve hanging out in the spinal glenoid notch. That's really important because that nerve is, sometimes you'll see like a paralabral cyst. That may be a potential target for a suprascapular nerve block. And there we go. So that's a scan on the shoulder. So have fun.